Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Unmasking Facial Pain, Exploring the Causes and Treatments. It's my pleasure to introduce our speaker, Dr. Meredith Barad. Dr. Barad is a board-certified neurologist, headache, and pain physician whose primary focus is helping patients with head and facial pain. She has collaborated in creating a cross-disciplinary headache center and is the co-director of the Stanford Orofacial Pain Program. Throughout the talk, please enter any questions into the Q&A at the bottom of your screen, and at the end of the talk, Dr. Barad will answer as many of those as possible. Over to you, Dr. Barad.
Great, thank you. Okay, welcome everybody. Let me share my screen here and we can get started. My plan is to try to talk for about 40 minutes and then save some time for questions. So let's talk about facial pain. There's a lot of different types of facial pain, and these are sort of the main types as I see it and break it down. Dental pain is by far the most common type of facial pain, and this is a very, very important type of facial pain, but not one I can really help you with because I am not a dentist. That being said, it's important to not forget that facial pain can often be caused by the teeth. But then as we start to get into the temporomandibular joint and temporomandibular dysfunction, that are areas that I can help you with. In our pain center here at Stanford, we actually have a collaborative program where we have a dentist who is an orofacial pain specialist, and myself, a neurologist, and then trained in pain, interventional and pain management. And so we work together with several other of our colleagues to diagnose and treat facial pain. There's also neuralgic types of facial pain, and that means pain caused by nerve irritations or nerve injuries. And probably the most common one you've heard of is trigeminal neuralgia, but there are other forms of neuralgia as well. And then there is neuropathic pain, which is pain that is usually due to nerve injury, and that has a little bit of a different presentation than neuralgia, which we also talk about. And then there are some other types of pains, pains that we don't know much about, like burning mouth syndrome, which is what BMS stands for. And those are pains that we need to do more research into and try to understand better. Okay, so we're going to skip over the teeth, but let's talk about the joint and the muscles surrounding the joint. So what is the temporomandibular joint? And there's a little box here at the very center. Actually, I don't know if you guys can see my cursor, but maybe I could do a laser pointer. Here we go. Okay, so there's a little box here, and this is where we see the joint. Here we have a big muscle. This is called the temporalis. Another muscle right here called the masseter. And if we open up and go to the inside of the jaw, we have the other muscles of mastication. Mastication means to chew, the muscles that allow us to open and close our jaw. And those are the pterygoids, the lateral pterygoid, which is above, and the medial pterygoid, which is below. And then we zoom in on the joint here, and the joint is two bones and a disc, just like many of the joints in our body. And this articular disc is sort of a cartilaginous structure that cushions the space between the bones so that they're not continually crunching on each other, and helps us as our jaw opens and closes and moves forward and backward and side to side. This disc helps cushion those bones as they move. A brief word about the joint. So typically we have this normal relationship of the disc, which is in blue here, sliding in and protecting the bones from each other as the jaw opens and closes. So when the jaw is opened, the disc is a little bit pushed backwards, and as the jaw closes, the disc comes forward. And so that's what we call the normal relationship of the disc to the joint. And as that disc moves within the joint, we call it translating. The disc translates through the joint. Sometimes it doesn't move so perfectly. So sometimes the disc gets a little bit out of place. It can get too far forward, and that can cause a click as you're opening your jaw, or it can get too far back, and that can cause a click as you're closing your jaw. And what that means, if you hear a click or a pop when you're opening and closing your joint, is that the disc is a little bit out of place. It might not be as extreme here as you see in these pictures. And oftentimes we are able to realign the disc without any problem. And so clicks and pops are pretty normal and quite common. Most clicking or popping sounds of the joint are not associated with pain. So in some studies, about 30% of adults report clicking or popping, but only about half of those patients report pain associated with that clicking. So if it's not painful, it's usually not a problem. Yeah, and in this large population-based study, most of the individuals, or a minority of the individuals with TMJ noises also reported pain. All right. So this statement, many patients come to me and they say, I have TMJ, which is basically saying I have temporomandibular joint, or I have shoulder, or I have knee. It is, yes, you do. You have two temporomandibular joints. And most of the time, they are not problematic. So let's just take a case here. We have a 31-year-old woman who says that she has pain localized in the left side of her face and jaw. So she's pointing kind of to this area, kind of like holding her hand right here. And the pain is moderate, steady, dull. When she chews, or if she's talking to her friends or talking for work, it gets aggravated. If she's like, goes to the dentist, it really bothers her when she has to open her mouth wide. And this pain has been going on for 3 months. She's felt worse for a while, but the last 3 months has really been bad. And she has achy teeth and sometimes pain that radiates into her left ear. But she went to the dentist, and the dentist says her teeth are fine. And then she went to the ENT to make sure that there wasn't anything wrong with her ears. And the ENT said her ears are fine. And she has no history of any noises, any TMJ noises or episodes of popping or clicking or locking. And we didn't really talk about locking, but locking would be the most severe case of that disc not going back and preventing the joint from closing because the disc is stuck. So she does not have TMJ. What she has is TMD, temporomandibular dysfunction or disorders. And these affect about 5 to 10% of the population. And it is simply put, mostly having to do with dysfunction of the muscles that surround the joint. And it can cause headaches. Sometimes people find that they are clenching their teeth more because they're having pain, or conversely, they clench their teeth and sometimes that contributes to pain. They can have pain at the joint, but they can also have pain all around the joint. Sometimes they can have clicking and popping, but again, that's not necessarily contributing to the pain. They can have neck pain and dizziness, and sometimes sensitivity to sound or dysfunction with hearing. All of these things can be caused by dysfunction of this area. And when you do a physical exam, you put your hands on the joint or the muscles around the area, and these patients still have tenderness. It's very rare that they would have like a hard time closing their jaw or kind of like creaking and cracking when they open or close their jaw. That's more concerning, that there's a problem with the joint itself. And so there's a really nice flow chart here in this review article from the American Family Physician Review article, where they sort of talk about how we evaluate this. And usually in a 31-year-old who's coming to me, I'm looking for some real reason for her to have some joint disruption. Did she have a trauma or a dislocation or a malocclusion? Maybe she had an abscess or something that's created that could cause a bony infection. And if that's true, then I may image right away. But if it's not necessarily that there's any trauma going on, and she's a normal, healthy 31-year-old, and there's nothing really abnormal on our physical exam, then I'm going to ask her if she has pain when she moves her mandible, if she has pain with biting or chewing, or if maybe she has some muscle spasm or tenderness when I push on the muscles surrounding the area. And depending on that, I will guide my therapy. So I want to just look at the right-hand side first, because that's really the most common thing. That patients come in, they have a lot of pain when you touch the masseter muscle or you touch the temporalis muscle. And these are patients who have some what we call myofascial pain. And what we do for them, or muscular pain, what we do for them is that we work on trying to help them learn to relax these muscles. See, it is necessary to sort of constantly keep these muscles slightly contracted so that your jaw is not hanging open all the time and spit's not coming out inside of your mouth. So we are at baseline sort of contracting the masseter, the pterygoids, and the temporalis to keep our jaw relatively closed. And sometimes that amount of muscle tone can be intensified by our behaviors. Are we clenching all the time? Are we a gum chewer all the time? Are we, usually clenching is kind of the biggest behavioral modification, but sometimes people are, holding their face in a grimace all the time and really using those muscles. Sometimes they're chewing really, really intense foods that are hard on the muscles as well. And so what we want to do is work on behavioral strategies, work on relaxation strategies, and then maybe work on some muscle relaxations through management of medications like muscle relaxants or nonsteroidals. And if we're still not getting anywhere, then we may consider some neuropathic pain medications like nortriptyline or amitriptyline or gabapentin. Sometimes we can do some injections, or do what we call trigger point injections into these muscles, or Botox into these muscles. Sometimes we will make a splint if they're clenching all the time to try to help get them into a more relaxed state. And sometimes we do need to consider imaging, but that's not usually the case for muscle spasm. If they're having a lot of pain with biting or chewing, then we will also make sure that they're not having any parafunctional habits. And these are kind of interesting. These are sort of unconscious habits that people develop that can aggravate their muscles. For example, if you're a lip chewer or a nail biter or really excessive yawner or really excessive clencher, then you can develop these pain syndromes, muscle pain syndromes primarily, that require education, behavioral modification, sometimes some physical therapy to help get out of that situation. And then if we find that we have somebody who's having movement of the mandible that's really painful, so painful clicking or popping, that's when we might consider more imaging. We still might do conservative therapy, ask them to not eat hard foods, ask them to not open their mouth for a major range of motion, try a little bit of nonsteroidals, try to reevaluate, but that's more where we look at the imaging. So again, a few pearls on TMJ. It does, the joint TMJ only refers to the anatomic part of the body, doesn't refer to the disease process. When we talk about a problem with the actual joint itself, we usually talk about arthritis, meaning inflammation of the joint, or arthralgia, irritation of the joint, and there are a lot of disorders that are under the umbrella that these TMJ disorders, the disorders of the actual joint, are under the umbrella of a bigger title called temporomandibular disorders. And that's, those involve both painful and non-painful disorders. But not, and so that brings me to my next point, not all TMDs are painful. And the ones that we see most commonly are the myofascial ones. These are some of the exercises that you learn how to do when you go to physical therapy that help relax the muscles. And they seem kind of simple, but oftentimes people don't realize how tense their muscles are getting while they're sitting at the computer, or while they're driving to work, or while they're at home getting in a fight with their teenage daughter, for example. And so sometimes it really helps to go through a brief course of physical therapy and understand how tense your muscles are and how to relax those muscles. Just a little picture of some of these muscles. They can be quite big. All right, so moving now on to the next type of nerve pain. We're going to talk about a different type. 40-year-old male who was playing basketball in a weekend league and got an elbow to his cheek. And he had immediate swelling, goes to the emergency room, and is told he has a fracture of his cheekbone. We call that the zygoma. And it's not displaced. There's no casting or anything. He just has to wait for it to heal. But he does get some numbness that's traveling down his face and shooting into his right cheek and into his teeth, and it's painful numbness. And 3 months later, it's still there, and comes the doctor concerned about this painful numbness. And so this is a problem with a branch of the trigeminal nerve. This is not trigeminal neuralgia. This is a nerve, an isolated nerve injury. And you'll see that the trigeminal nerve is a very big nerve. It has 3 different branches, which we call V1, V2, and V3. And within each branch, or division, I should say, there are individual nerves. So in this case, our gentleman fractured his zygoma, which is right here, his cheekbone, and there's a nerve that comes out there called the infraorbital nerve, and he injured that nerve, and there's some numbness and some pain going along that cheek area down to the tooth. And that will probably heal over time. But nerves take a long time to heal, and it's very annoying for people because they just want it to get better, but 3 months it's not really better, 6 months it's not really better. Sometimes it can take an entire year for a nerve to heal. So it definitely takes a lot of patience. And sometimes there's some medications that we can use to help if the pain is challenging to bear. So there Tylenol and ibuprofen can certainly help, but things like gabapentin, right, amitriptyline or nortriptyline can also be used, Lyrica, to help quiet down that sensation so that's not quite so problematic. But there are other types of trigeminal nerve problems. And so let's take this case where we have a 65-year-old woman, and she has no past medical history, and then she presents with pain in her right upper teeth. And she states that the pain occurs about 2 to 10 times a day, It's brief, only lasts for seconds, but it stops her in her tracks. And it's sharp and electrical and quite debilitating. She's been to 3 dentists and she's had x-rays and she had a tooth removed, but the pain continues. And when she shows up in your office, she's wearing a scarf wrapped around her face. And she says that she has to wear that because if the air conditioning hits her face, it will set her off. And when you examine her, you palpate her sinuses, make sure there's nothing going on with sinus infection and stuff. And you make sure that there's no sensory loss, so it's not numb in the cheek like our other patient, but it is very sensitive. And so she really doesn't like you touching it, kind of pulls away when you do touch it. We call that hyperalgesic, so more sensation than one would expect to feel, or more sensation than the opposite side. And so this is probably what you've heard more commonly talked about in chat groups and online. And this is what we call trigeminal neuralgia. And that is a pretty rare condition. I mean, lifetime prevalence of up to 0.3%. So not something that you're gonna just get. But it does happen in women more than men, and it does happen as we get older. So the average age of onset is in our 50s. And it has these very particular features. So sharp, shooting, stabbing, electrical pain. People use the word zapping and electrical and shocking and startling to describe the pain. And in medical language, we call that lancinating pain. And a small number of people also have continuous pain, underlying continuous pain in the same area. So they will have like an underlying dull throbbing or aching pain, and then on top of that, they will get the sharp shooting pain. It's often felt in the cheek area and the jaw area. That's called the V2 distribution, so the second branch of the trigeminal nerve, and the V3, the third branch of the trigeminal nerve. Interestingly, it's usually on the right side, or sorry, I should say more commonly on the right side than the left side, but people feel it both in the mouth and outside of the mouth. Sometimes you can have some tearing or some runny nose on the, sorry, this is medical language, ipsilateral side, so the same side as the pain. And just like that lady had a trigger, there are other triggers that are kind of key for us. So patients who get pain when chewing or toothbrushing or washing their face or light touches or talking, those innocuous triggers are very common for trigeminal neuralgia patients. And oftentimes patients will say that like just touching certain places, especially this area, like the nasolabial fold, the upper and lower lip, like right around the lip, the chin, or sometimes the gingiva, like the gums. Those can be particular triggers for people. And so I want to just back up because neuralgia is a big word and we probably should define it. So what is neuralgia? Neuralgia is an intermittent attack of one-sided pain in the distribution of a particular nerve. And you can have a neuralgia of any part of your body, any nerve in your body, and it's usually due to an injury of some sort. The pain has all of the following characteristics. It lasts from a few seconds to a few minutes. It's severe in intensity. It's shooting or stabbing or sharp in quality. And it seems to be precipitated by stimulation of a trigger area. Now, trigeminal neuralgia is a little bit different than other neuralgias in that the way we define trigeminal neuralgia nowadays is that it is a nerve that is compressed by a blood vessel, usually, with changes in that nerve due to the compression. And so what we've learned about trigeminal neuralgia over the years is that the injury is not is a long-term slow injury to the nerve that is due to compression by a blood vessel. So a blood vessel slowly pushing on a nerve over time will change the shape of the nerve over time. And that is what we call classical trigeminal neuralgia. And our knowledge of trigeminal neuralgia and the fact that if you compress a nerve, that as it comes closer to the brain, which we'll talk about in a minute, has informed our understanding of other neuralgias in the head. And many surgeons have now treat all facial neuralgias. They look for decompressions, look for blood vessels that are compressing the nerves first. There are other reasons why why trigeminal nerve can be irritated. We call these secondary trigeminal neuralgia cases, and multiple sclerosis is the most common secondary trigeminal neuralgia. You could also have a space-occupying lesion, like a tumor, or sometimes another disease process. And then there's idiopathic TN, meaning we don't really know what is causing it. There's no mass there, there's no lesion, there's no other systemic health problem, and there's no compression. And we think this latter category may be due to spontaneous genetic mutation in sodium channels that can create some changes in how the nerve fires. So what is happening in trigeminal neuralgia is that the nerve is compressed in this area called the root entry zone. And this is an interesting area. It's a transition area. So as the nerve passes from the periphery and it enters the brain, it has a different coating on it. It has Schwann cells, and then it changes to oligodendrocytes. The coating on a nerve is really important because it helps the nerve convey messages rapidly. If the nerve doesn't have a coating, it can't convey messages to the brain very rapidly. So this coating lets the nerves communicate with the brain. And as they come in from the periphery and enter the central nervous system, the cell that coats them changes. And during that transition, the nerve is vulnerable to compression and demyelination. Demyelination is destruction of the coating, and then that leads to misfiring and excitability of the nerve. Okay. So how do we treat trigeminal neuralgia? Surgery is a very, very, very good option, and we're going to talk about it. But before we get to surgery, brain surgery that is, we often say maybe we should consider some medications because sometimes we can get a win with medications and the trigeminal neuralgia will settle down and we may not have to have a surgery. Trigeminal neuralgia is a relapsing and remitting disorder. And the key is to try to do surgery at a time when you feel like you either can't tolerate medications anymore, or you're not, or you need to be off of the medications for some reason, or they're not helping, or you don't want to miss your surgical window. Sometimes we can get to a point where we have too many health problems and we're too old to have surgery. I don't want to say too old, but our health problems are such that it would be a bigger risk for us to have surgery, to have a general anesthesia. So we don't want to wait too long to have surgery, but we also, if we could get by with a manageable level of medication, maybe we can wait a little bit longer before having a surgery. So these are the medications that we use to treat trigeminal neuralgia. Carbamazepine and its sister drug oxcarbazepine are the classic meds that we've used for a long time to treat trigeminal neuralgia. And they are also used to treat other neuralgias, but it seems like the trigeminal nerve is particularly responsive to these drugs, which are sodium channel blockers. And these are the doses, and we do a little bit of testing to make sure that you're a good candidate for this kind of medication before we start you on it. And depending on the patient, they're usually well tolerated, but every patient is different. And so your doctor has to be willing to work with you and to slowly titrate these meds to try and find the right combination, the right dose, and the fewest side effects for you. Okay. So let's say you try some medications for a little while, symptoms go away, but then a year later they come back, and this time you go back on the meds, but it's not working, and you're in a lot of pain, and you get an MRI, and your MRI shows that where this arrow is, that there's a blood vessel that's sort of sitting on top of the nerve, and this black area that's heading straight up is what turns into the trigeminal nerve, if you follow it, and the blood vessel is sitting on top of it, superior cerebellar artery. And so the idea is to decompress those. And this photo was given to me by Dr. Lim, who is our chief of neurosurgery. And Dr. Lim is a specialist in trigeminal neuralgia and microvascular decompressions, and quite a great surgeon. If you ever, hopefully you will never need to go see him, but if you do, he's wonderful. And microvascular decompression is one of these rare wins that we have in pain. So in pain, we don't have a lot of wins. We don't often have patients that, well, it is becoming a little bit more common than when I started, but when we quote success rates for MVDs, we say that about 80% of patients are pain-free. That's very amazing. In pain medicine and in our pain procedures, I can't really tell you that 80% of you are going to be pain-free with any of my treatments. But this surgery seems to be quite spectacular for many, many patients. And even though it is brain surgery, and even though that does sound scary, it's a fairly minor procedure where they are, I think I have a picture here, they're opening up a little bony window to help access the brain, and then putting a small Teflon pad between the trigeminal nerve, which is the V, right here, trigeminal nerve, and the superior cerebellar artery right here. And that Teflon pad prevents the rubbing of prevents the artery from rubbing and irritating the nerve. So we've applied that strategy to other nerves. And actually, I'm going to come right back, but let's go to glossopharyngeal neuralgia. And so glossopharyngeal neuralgia is characterized by a deep inner ear pain and a pain at the back of their throat. And sometimes it can also cause vagal neuralgia, and that can lead to, because those two nerves are very close to each other, and as they enter into the brainstem, and it can cause slow heart rate, sometimes passing out, low blood pressure, and sometimes some swallowing difficulty and some hoarseness. So applying that strategy to the glossopharyngeal nerve, this is a picture from a non-Stanford group of putting a Teflon pad, or Teflons, several different pads, in between the nerves, which are where the arrows are here, the vagus and the glossopharyngeal, which is 9 and 10, and then the pica, which is the blood vessel that is compressing them. And so basically you're kind of separating the area. And so we also do that for a condition called hemifacial spasm, which is caused by a compression of the facial nerve. And then for geniculate neuralgia, this is a small branch of the facial nerve that has some sensory distribution that causes pain deep in the inner ear. And then sometimes it radiates actually into the back of the head, and sometimes it can radiate into the face. And the jury's still out on if we cut the nerve or we do a microvascular decompression. But I put this picture in here because it's, again, from our neurosurgery division, and you can see how they make this little bony window, remove a little bit of skull, open up the dura, do the surgery, and then close it back up with a little bit of bony cement and sew it back up. And I will tell you that most patients tolerate a procedure like this very well. All right. So that's neuralgias. There's one other type of neuralgia, and I'm going to present a case here of a 30-year-old who had a pituitary tumor. And here's where the pituitary lies, the tip of this arrow here. Sorry, this picture's a little blurry. And so he had this surgery where they actually go through your nose, through the sinus, through another sinus, which is called the sphenoid sinus, and then to access the pituitary. And post-surgically, he had a lot of facial pain. Sometimes he had some tearing in his right eye and some dripping mucus coming out of his right nose. And this was just a sharp pain, but an aching and nagging pain. It would last hours to days and go away, and then it would come back. And it was very, very hard for him. And so this is another interesting type of neuralgia, which we call Sluder's neuralgia or SPG neuralgia. And it is a little nerve bundle that lies behind your ethmoid sinus, so behind this sinus, and is very closely related to the trigeminal nerve. They hang off, they almost sit right next to each other, but can cause pain in the back of the sinuses, in the upper palate, back of the throat, and into the pituitary. And so sometimes patients are having middle face pain, midline pain, and a lot of different headache syndromes seem to be related or modulated by this nerve. And so we do a lot of nerve blocks to this nerve. We have a lot of different ways to block this nerve and have learned a lot about it in the past 5 years. All right, so moving on, I wanted to bring to your attention that there are some headaches that can masquerade as facial pain. So there are patients who can have migraine that only occurs in the face. So you don't feel it up here, but you feel it in your cheek or your ear or your jaw, and it is, or just your eye. And typically these patients have a lot of the features of migraine. So the duration will be the same as migraine, lasting 4 to 72 hours. The characteristics of the pain are similar to migraine in that it's unilateral, pulsating, moderate to severe in intensity, aggravated by physical activity, and with some nausea and light sensitivity and sound sensitivity. And then there's a form of this type of migraine, which is chronic. So a migraine that occurs more than 15 days a month, but again, just in the face or in the mouth also. And then there's tension type orofacial pain, and that's episodic or chronic pain exclusively in the face that doesn't have the features of migraine. So it doesn't have light sensitivity or sound sensitivity or nausea, but it does have this tension type pain. And a lot of those patients go to the sinus doctors because they think that they have sinus infections again and again and again. until the sinus doctor goes and looks and doesn't see anything, and says, I don't think we're dealing with a sinus infection. And then some patients can have orofacial, trigeminal autonomic orofacial pain. So this is an attack exclusively in the orofacial region with features of tearing in the eye, runny nose, sometimes redness of the face, sometimes swelling, sometimes droopy eyelid, we call that ptosis. And depending on the amount of time that it lasts for, that kind of helps us determine the name of it. So for example, if it's a cluster headache or cluster orofacial pain, it will last for 15 minutes to 2 hours and just stop. And so that is kind of an interesting feature of we call them in the head, we call them trigeminal autonomic cephalgias or TACs, but they also exist exclusively in the face. All right, and then finally, we have a condition of a 52-year-old female who comes to me saying that her tongue is on fire. She entered menopause several years ago, and she has noticed that recently in the past couple months, her tongue feels hot, like it's on fire. She can't really eat or drink without significant discomfort. And this is a problem because she's a sommelier, very hard for her to do her job because of her tongue pain. So she went to ENT, otolaryngology, and they ruled out any tongue pathology. She also went to the dentist who did a tongue exam and a dental exam to make sure there wasn't any tooth issues that were contributing to this. But this syndrome is called burning mouth, and it's a very challenging syndrome. We think that there are different forms of it. We think that the primary form may be due to injury of small nerve fibers on the tongue, and that can heighten pain sensation. We also think that there may be some dysfunction of dopamine receptors, although that's very nascent. Not a lot of, maybe 1 or 2 studies that are looking at that. There are a lot of secondary causes of burning mouth syndrome, which if we catch early enough, we can treat and reverse the syndrome. So poorly fitting dentures or people with parafunctional habits that we like we talked about earlier that can cause microtraumas. Sometimes like pursing your lips or biting your lips or clenching really intensely can damage the tongue. Infections like fungal infections like candidiasis or lichen planus, allergic reactions, which can cause the use of some medications. So both allergy and sometimes use of antihistamines or antihypertensives or angiotensin converting enzymes or antiarrhythmics can aggravate and cause burning mouth. Benzodiazepines are usually helpful, and people will say that Ativan, Valium, lorazepam medications really, really help. Oftentimes people can have vitamin deficiencies that can lead to burning mouth syndrome, GERD, reflux diabetes, hypothyroidism. Sjogren's can maybe lead to this because of the dry mouth, and also perhaps estrogen. The decline of estrogen that occurs around menopause may be involved in this pathology. So this is something we really don't know enough about burning mouth syndrome. We need to study it more actively. But the treatment options are benzodiazepine first and foremost, which really seems to work well. That being said, doctors don't like starting patients on benzodiazepines because they are hard to get off of once you start on them. And there is some evidence that some studies that suggest that it can be more challenging for you if you're on benzodiazepines as you age. May have a higher risk or a higher correlation of having a degenerative disorder like Alzheimer's And we can discuss that, in a whole nother lecture. But in general, we like to use benzodiazepines as minimally and rarely as possible. So we try other medications like gabapentin, tricyclics, alpha lipoic acid, something called topical capsaicin, which is made from chili peppers, the compounds in chili peppers, and maybe estrogen. Maybe there's a role for estrogen in the right patient who experienced this directly correlated to the onset of menopause. All right, so I think I went a little over time, I apologize, but these are the types of different types of facial pain that we talked about tonight. There are more that we didn't quite hit on. We could do a part 2 if you like. But now I'd like to open it up for questions.
Thank you, Dr. Barad. Many of the questions were answered in the lecture, but I'll continue to ask the ones that are in the chat. And if anybody has any more, please put them into the Q&A. Here's one. What is the prevalence of trigeminal neuropathy due to ADEM in adults?
I'd say ADEM is very, very rare to begin with. And so I would say that's quite rare. I don't know that I've ever seen a case.
Somebody asks, how do you measure the pain besides through pain scales? Is there an objective way to measure pain?
Well, this is a really challenging question. Pain is a subjective experience. That is part of the definition of pain. It depends on how your nerves send signals to your brain and how your brain processes those signals. So we don't have an objective test that says this person's in pain or this person's not in pain. There are many people that are interested in looking at imaging, both in the spinal cord and in the brain, to help us understand where pain is processed in the brain and how actively the brain and spinal cord are working to process the pain. And the other thing that we measure is the impact that pain has on your life. So what we know is that pain disrupts your sleep, it disrupts your mood, it disrupts your ability to interact with friends and family, and leads to social isolation. And it disrupts your general well-being. And it can create depression and anxiety. And so we measure all these other factors and come up with some benchmarks for the patient. Here's where you are today. Here's what all your tests show in terms of where you are with your mood and your function and your social isolation. And as we treat your pain, and also sometimes we have to treat the mood disorders, and we have to help reintegrate the person into activities and exercise. But then we follow those benchmarks to see if we're moving in the right direction.
Thank you. Do you have any advice on when to get a second opinion when you're getting treated for pain?
Well, I think you got to trust yourself. If you're not feeling like the relationship is working, or you're not hearing things that make sense to you, then I think you should get a second opinion. You want to be satisfied with your doctor, and you want to have a good working relationship with your doctor, because pain is not an easy, like, we're done type of situation. It usually involves working with your doctor over a period of time, sometimes years, to try to minimize the pain and improve the function.
What do you think about deep brain stimulation?
For facial pain, I think it's interesting. So we have a doctor here, Ashwin Ramayama, who is very interested in it, and is looking at targeting different parts of the brain, first determining where to target, and then looking at how to target these parts of the brain for different facial pain conditions, mostly end stage. Like, we've tried everything else and we just haven't been able to help patients. So again, I think we have excellent neurosurgery department that's really interested in exploring new treatments for patients with chronic pain and thinking outside of the box, and DBS is part of that.
What do you think of the use of triptans in idiopathic atypical facial pain?
Well, I would say why not try them, because they're fairly harmless and we could be missing an orofacial migraine that we just didn't appreciate. So I don't think it's silly to try a triptan for a facial pain diagnosis when other things haven't worked.
Those are
Sorry, and just to clarify, triptan is for migraines traditionally, just so everybody knows.
Well, those are all the questions that we have in chat. So thank you so much, Dr. Barad, for sharing all this great information. And thank you to our audience for joining us and for the great questions. If you'd like additional information or resources, please contact Stanford Health Library, and we hope we'll see you at our next lecture. Good night.
Thank you, everybody.